Thank you. It is such a privilege to be with you, to be giving this talk. And over the next 40 minutes or so, I'm going to be talking about an approach to identifying and diagnosing the complications of diabetes. And this is going to take a far broader conversation than just measuring the HbA1c, measuring the glucose, and seeing what to do thereafter. Because actually, diabetes is a far more complex disease than just that. So I'm going to start, as usual, with my conflicts of interest. I am receiving an honorarium to give this talk today. However, I have prepared all of the slides my own. They're all my own material, many of them my own studies, and therefore there's been no outside interference or involvement in creating this slide deck or with anything I'm going to be saying. I also start every presentation I do with this slide. This is my disclaimer. These are the words of Abraham Lincoln, who very famously said, "Never allow scientists to partake in government. If you give them a new piece of information, a scientist will change their mind." Now, I use this for many reasons, but predominantly because actually in early diabetes, both in the diagnosis, the management, and the interaction with the comorbidities, there is a massively rapid evolving information set talking about how best to manage this. And therefore, what I'm saying today may not still be the case tomorrow. It may not be the case in 12 months' time. But this is the best of the information that we have at this moment in time. So I was asked to talk about the diagnostic criteria for diabetes and the metabolic syndrome and how this all fits together. And I can actually do that very, very simply. These are the numbers. These are the numbers that we need to be looking at on a regular basis. We look at the HbA1c, we look at the fasting plasma glucose, or we look at the oral glucose tolerance test. And in order to make the diagnosis of diabetes, you need symptoms plus any one of these. If they're asymptomatic, you need 2 of these tests in order to find out what the right strategy for treating our patients is. And these numbers are really, really simple. The fasting plasma glucose, the HbA1c, if it's less than 5.7%, that's normal. If it's 5.7 to 6.4%, they're in a pre-diabetes range. And if it's greater than 6.5%, then they have diabetes. Now, it's very, very important to be aware of the fact that that is based on a normal hemoglobin without any blood loss and without any other hematological diseases. So our patients with thalassemia, patients who may have other diseases that are causing hemolysis, patients who might have increased blood turnover, their A1Cs will be artificially changed. Remember, your HbA1c is an average of the exposure to your glucose to the average of the life expectancy of the red cell. Providing that red cell is lasting for 3 months, this is a valid measure. If the red cells have a protracted duration, so for example, the very elderly patients whose red cell life is much longer, or patients who've got diseases like thalassemia or sickle cell, or patients who are losing blood through GI disturbance or infectious diseases, then an A1C will not be valid. And for those individuals, we have to look at an alternative route of making the diagnosis. The next thing that we may look at are the fasting plasma glucose. Now, fasting plasma glucose gives you the snapshot of the glucose at that one particular time. And if it's less than 100, you are fine. If it's 100 to 125, you're in the pre-diabetes range, and greater than 126, you are regarded as having diabetes. The problem with fasting plasma glucose is there are other things that can influence it. Remarkably stressful events, right down to what you actually ate when you finished eating, and what your night's sleep was like in order to determine it. So although for years the fasting plasma glucose was accepted as a standard, there is a greater push recently to switch, if you can't do an A1C, to do the oral glucose tolerance test. That is, you give them 75 grams of sugar, and then you find out what happens to their blood sugar afterwards. And if your blood sugar rises at 2 hours to less than 140, you don't have diabetes. 140 to 199, you're in the pre-diabetic range, and 200 or above, you have diabetes. Now, you'll notice that these numbers appear somewhat rounded. These numbers appear rather arbitrary. And the reason for this is very simple. They are. Diabetes is a continuum. Diabetes is not necessarily an absolute cutoff. The majority of people living with diabetes have been in a pre-diabetic state for 6 or 7 years before their first glucose is arrived. The reason that those particular numbers have been chosen is, well, that was based on historic figures that said this is where the risk of diabetic retinopathy suddenly starts to shoot up. And if your diabetic retinopathy shoots up, then there is chances are that other diseases will also be shooting up at a similar time. And that's the sole reason about why we have these percentages cut-offs. And this concept of diabetes and glucose and the management of diabetes and glucose is by no means new. It was recognized 3,500 years or so ago. Actually, one of the first people who recognized this was the physician Hesi-Ra, an ancient Egyptian physician of around 152 BC, well, sorry, 1552 BC, who described this condition that was affecting the affluent. It was affecting people of greater girth, he described it. Basically, the people that we would today recognize as having insulin resistance. The central adiposity, the visceral adiposity that we know is associated with insulin resistance. And it's associated with frequent urination. And he treated this with an extract of the French lilac. French lilac, otherwise known as goat's rue, or today, we would call that metformin. And actually, the management of type 2 diabetes from the outset has been recognized to be metformin not since 1958 when the drug was first developed, but for 3,500 years since Hesi-Ra was first using this as a treatment for his patients living with this disease. Now, there has then been a significant evolution of the management of diabetes over the last 15 to 20 years. If you go back to 2007, we managed diabetes on a three-pronged approach. Because actually the understanding of diabetes was that you weren't making enough insulin. The insulin you were making was being inhibited, it was impaired action, and that you had a dysregulation of your glucose metabolism. You had an increase in the glucose absorption. And therefore, our management of diabetes was based around those three key goals. We had the alpha glucosidase inhibitors that we were able to reduce the glucose uptake. Impaired insulin action, the insulin resistance was tackled with thiazolidinediones and metformin. For beta cell dysfunction, we would stimulate the beta cells with sulfonylureas or the glinides, repaglinide or nataglinide. However, this all changed dramatically when Ralph DeFronzo in 2009 published that glycemic control was not the root problem in diabetes. Actually, glycemic control is no more than a symptom of diabetes. It was a significant shift in the way we started to think about diabetes. And Ralph DeFronzo presented the Banting lecture at the EASD and then went on to write this landmark paper that said hyperglycemia is a symptom of a disease. The disease itself is characterized by reduced alpha cell production of glucagon, reduced beta cell production of insulin, of incretin deficits, the changes in the GLP-1, the GIP, of changes in our relationship with food, this neurotransmitter that patient living with diabetes actually doesn't feel full in the same way as somebody without diabetes. They are therefore hungry much, much sooner and would like to eat their next meal. They have a change in the relationship between glucose and fat metabolism, such you see an accelerated lipolysis. But this will be very low density or LDL fat that's released. And as a result, this has a far more atherogenic effect. Our muscles are not able to utilize the glucose properly. The effect of this is people living with diabetes have a reduction in their efficiency of about 20%. That's why for exactly the same effort, for exactly the same muscle mass, a patient living with diabetes will experience a generalized weaker response. The livers change their interaction, that they will increase glucose production even at a time that they've just eaten a high carbohydrate meal, therefore further fueling the central adiposity. And once we've got used to that, once this glucose is elevated, the kidneys stop excreting it. They start upregulating the SGLT1 and 2 pathways that cause an increased glucose retention. So even when there is hyperglycemia, the body doesn't deal with it in the usual way. Now, this sat in the right place until about 3 years ago. And 3 years ago, we added in that there is a change to the microbiome. There is a change to the way that the gut is associated with glucose. There was some really elegant work done originally with rats that demonstrated if you change the microbiome, those bacteria living in our gut, you can actually change the glycemic dysregulation. It was also highlighted that the entire inflammatory pathway was modulated in people with diabetes, even in the setting of normal glucose. So glucose management itself was not, on its own right, able to fix people. We also saw that there was a change in the gastric absorption of glucose, that it would be reduced in the stomach in people living with diabetes. That meant it was more likely to get to the lower bowel, where it would have a different impact on the incretin system. And similarly, it would cause some of this microbiome dysregulation. Now, the microbiome dysregulation and the reduced amylin that leads to increased glucose absorption in itself are very closely interplay. And there's still an uncertainty today as to which comes first. Is it you change your glucose absorption, which then changes your microbiome? Or does your microbiome change, which causes differences in your amylin secretion and therefore your glucose uptake? Whichever of those it is, the net result is the hyperglycemia that we see. However, with all of this, you can see that hyperglycemia is nothing more than a barometer. Hyperglycemia is very often not the underlying disease. It's like taking a temperature of a patient who's got pneumonia. Fixing that temperature, giving them the cold baths or the paracetamol is not going to take away the pneumonia. Measuring the glucose is an indicator of inflammatory dysregulation in neurotransmitter dysfunction and insulin resistance, but fixing the glucose doesn't take away those particular elements. Now, things were then latterly made further complex by the identification that diabetes itself is not a single disease. Although we recognize diabetes as hyperglycemia, then actually it's a whole load of different characteristics. There is a classic insulin-resistant diabetes, which does account for a large number of people living with diabetes. We then see severe insulin deficiency diabetes. Now, this, even in the setting of type 2, is just down to pancreatic failure. And we know, particularly with sarcopenia, with frailty, with our very elderly population, their pancreas can fail in exactly the same way as every other organ can fail. And these look, to all intents and purposes, like a person living with type 1 diabetes. They'll present with diabetic ketoacidosis, they'll present with catabolism, weight loss, and all of those things that go with that. And they usually require early insulinization. At the other end of the spectrum, we've got this mild age-related diabetes. This is something we see in older adults in their 8th or 9th decade. And what we see here is just the red cell duration lasts a bit longer. You get reduced erythropoietin and then a reduced red cell turnover. So your same glucose has a greater chance of bumping into the hemoglobin, and you see this artificial elevation of your HbA1c. There is a question at the moment as to whether these people need treatment at all. And these do have quite a significant implication when it comes to managing patients living with diabetes. Now, for the rest of this talk, I'm going to be focusing mostly on the insulin resistance phenotype. And the reason for that is twofold. The first is this is the one that we know most about. This is the one that we've got lots of therapies for. And the second, by far and away, this is the most common form of diabetes that you will see in Bangladesh. In Bangladesh, this accounts for about 90 to 92% of the type 2 diabetes that you'll see. And that component fits as a core element of this whole cardiorenal metabolic system. And again, this is another development of the management of diabetes. The cardiorenal metabolic system is being more and more identified as a single entity. The heart is by far and away the most metabolically demanding organ in the body. It is incredibly susceptible to change in volume, change in metabolism, changing in workload. And it can only do this providing it is mirrored with the right amount of support from the energy and also the right amount of support when it comes to waste products elimination. Energy is maintained by the liver and the pancreas, whereas the kidneys are involved in the homeostasis of the glucose and the volume, and also the regulation of the perfusion that it manages to achieve. And all of these systems are significantly interrelated. If one goes wrong, you can expect the other two to start failing. When we start to see failure in metabolic regulation with the liver and the pancreas, with insulin resistance and diabetes, the heart cannot function normally. The kidneys cannot excrete properly. So you will see decline in both of them. If you start to get heart failure, you get lack of perfusion, which means the tissues stop to experience the nutrients and the insulin that they require. Therefore, they send the catabolic messages back to the body, which in turn triggers the renal impairment. If you get renal impairment, then what you see is a volume expansion. You see the pollutants hanging around in the body much longer. Therefore, neither the heart nor the metabolic pathways are able to work appropriately. The net effect of any of these three is it will trigger problems in the other two. And therefore, when we're considering our patients with diabetes, we have to consider where do they fit on this entire continuum? Where do they fit on the endothelial dysfunction, the atherosclerotic, the cardiac disease, the renal impairment, the heart failure, and what is the glycemic actually representative of? Now, I've spoken about these three interplaying. There is a fourth condition that is rapidly being recognized as having a significant component of this. And this is really only in the last 2 to 3 years that we're starting to appreciate that when you get the metabolic problems coming from the pancreas and the cardiac dysfunction and the renal dysfunction, the liver also starts to suffer. And we are seeing a dramatic increase in patients living with type 2 diabetes, with obesity, with the non-alcoholic fatty liver disease, or the subsequent iterations of that, with NASH, and living with CVD. And all of these diseases are interplay. So therefore, if you are working with any one of these diseases, you are automatically working with all four. And then the knock-on effect is absolutely huge. Any patient living with adiposity, living with obesity, is going to be associated with a considerable other condition. So if, for example, you're seeing somebody in an asthma clinic or an infertility clinic, they are far more likely to be living with obesity. And if they are living with obesity, they will then have many of these knock-on consequences. And fixing them might improve the underlying condition that you started seeing people for. They also get mechanical problems. So we see difficulties with physical functioning. Low back pain occurs in about 80% of patients, and actually a very common presenting feature for any of these diseases would be presenting through their primary care practitioner as a simple, I am struggling to do my work because of the back pain that I'm getting. All of these will have a knock-on impact on the mental health of our individuals. And a patient living with obesity and chronic comorbidities will have an incredible level of depression, anxiety. Their ability to be productive will have a dramatic impact on their feelings of self-worth. Very often, this can cause family problems. This can cause issues where they are not able to contribute to the family structure in a way that they ordinarily would do. And now, going back through each of these in turn, I'm just going to take a moment to talking about how we can hopefully tackle this coming through. And the first thing I will look at is obesity. Now, obesity is a complex, multifactorial disease. We always used to be told that it's just a balance between too much in, not enough out. Then people started recognizing that there are neurological reasons associated with it that come in from the environment. Once upon a time, that it was prolonged periods of fasting was normal. These days, with the fast food and the environment and the socioeconomic pressures, it is almost impossible to get to a phase where we are not being tempted by foods that otherwise we may not have eaten. And the food companies are very much invested in making these more pleasurable. And in doing so, you're far more likely to engage. Now, the knock-on effects of all this affects our adipose tissues, the pancreas, the guts, the genetics, and the medications all lead into this. But actually, if we take the first of this, the adipose tissue, the pancreas, and the gut, that then becomes a positive feedback loop. That having problems with the food regulation actually triggers a positive feedback loop, such that if you eat more, your body enjoys eating more, and therefore you are convinced to eat more. Now, it's not quite as simple as just food on a plate, therefore you eat more food, because many of the hormones produced by the adipose tissue, the pancreas, and the gut are directly affecting the prefrontal cortex, the bit of our brain that determines when we're going to eat. They are then potentiated by the hedonistic inputs, right? The fact that you get pleasure out of eating certain foods. Now, there are different regulators of that, by the availability, the social cue, the food thing. But whatever those cues, they are all feeding in to the way that our hypothalamus responds. Now, the hypothalamus responds differently to food dependent on what stage of the disease process you're in. It produces a whole host of different chemicals to upregulate or downregulate satiety and hunger. So that we'll see things like arginine-related peptide that will actually inhibit satiety. It will tell you that you are not full. I don't care how much you've eaten, you need to eat more. And many of the chemicals that are produced that in order to try and prevent that, we start to lose in the management of diabetes. So leptin and insulin, for example, should trigger satiety. They should suppress hunger. But the reality is, if you start to lose sensitivity to these components, you eat a meal, you produce insulin, but your body doesn't know it's full. And therefore, an hour later, you become hungry again. The satiety peptides similarly will give you an altered response. We see in people living with diabetes that they have reduced levels of GLP-1, glucagon-like peptide 1, which is a really potent appetite suppressant. But the levels start to fall and the sensitivity starts to fall. We see polypeptide YY, PYY, also start to have its effect within the satiety centers. Ghrelin ceases to be produced, and all of this interacts with the hindbrain. And what we see is a change in the way our patients living with diabetes or obesity interact with food. Now, these primary neurons start to impact on the way that the body interprets its food cues. And as a result, we see patients self-perpetuating this obesity that has the longer term consequences. And so what we end up in a position is that we need to start tackling this at root cause. The days of managing obesity by saying, eat less, do more, have gone. We need to start tackling each of these consequences individually, and the sooner and better, because unless we do, we end up with the pathology digging in. We end up with hypertrophied adipocytes that become less effective at producing their satiety hormones. We see endothelial dysfunction, which leads to cardiovascular disease, and we see increased fatty liver, which changes your fat metabolism, and in doing so also causes more atherosclerosis. We see changes in the activity of the pancreas and the muscles. The net effect of all of this is obesity does not just cause the waist circumference to expand. It causes a substantial change in the way that that our entire body is able of functioning. And the sooner we treat that, the better. Waiting till patients need interventions with injectable therapy or even surgery actually is a much more difficult challenge to gain benefit. If you can get to someone with a healthy BMI of about 18.5 in a Bangladeshi population and stop them rising, it is far more effective at preventing each of those complications. But the more weight you lose, the greater the benefit. And earlier interventions with drugs that promote the weight loss, such as metformin, such as the DPP-4 inhibitors that produce a more regulated interaction with the with food, will have a much greater impact when started earlier in the disease process. And the sooner we start it, the sooner the benefit. Because once it's entrenched, then we see this three-way dysfunction. The cardiac dysfunction in itself leads to hepatic dysfunction, and hepatic and pancreatic metabolic dysfunction leads to renal dysfunction. And each of these elements have the interplay such that the majority of the patients that we see will have problems in one or other of the domains if any one goes wrong. I just want to take a quick moment to go through some of the diagnostic criteria. And for many of you, this will be second hat, but I just want to take a moment to talk about how we are doing some of the other diagnostics. So, for example, glomerular filtration rate is actually something that's relatively new since I started as a doctor. When I was a trainee, we just measured creatinine, and creatinine was all we needed to look at. We've now moved to almost universally measuring the glomerular filtration rate. And the EGFR, estimated glomerular filtration rate, is a composite of two particular variables. How much every single glomerulus will filter and how many glomeruli you've got left. And we calculate this using equations based on the renal function, the creatinine, the body weight, the gender, and the other components. But the problem is, as your kidneys start to fail, as you start to lose glomeruli, the remaining glomerular heads have to start working harder. We know people living with diabetes actually have a dramatic reduction in the number of glomeruli. But each individual glomerulus then has to work much, much harder in order to try and compensate. As they start to work harder, that's the point that the basement membranes start to fail. And as they're working harder, they are then more likely to fail. So there becomes a catastrophic decline in the number of glomeruli. But by the time the decline starts, then it's actually too late to manage the underlying disease. And because of that, when we're looking at the diabetic kidney, we've moved away from just monitoring EGFR and are focusing far more about albuminuria and microalbuminuria. See, the reason is, as your glomerular pressure increases, as your filtration rate shoots up, before your EGFR starts to fail, the first thing that happens is these glomeruli become leaky. As a result, what we then start to see is leakiness that measures as changes within the microalbuminuria. Here's just an example, and I want to stress this is just an example that I've drawn out. It's not taken from any real patient, but this is a typical sort of course that would happen to the EGFR in a person living with diabetes. That the EGFR in the first stages would rise. That's because of the diuretic effect of the glucose, tied in with the fact that as glomerular heads start to fail, the upregulation of the remaining glomerular head actually overcompensate. And therefore, your kidneys have lost a dramatic amount of their activity before we start to detect the fact that the kidneys have gone wrong. But as I said, the albumin excretion rates starts to go up as soon as the glomerular heads start to decline. So if you monitor the urinary albumin excretion rate, you start to pick up the disease much, much earlier. So the standard that we are looking at now for monitoring our patients living with diabetes is not waiting for the creatinine to start fail, waiting for the EGFR to fall before we intervene. The standard now is looking early on, try and identify problems before they arise and prevent them getting worse. Now, when it comes to looking at the failure, EGFR is very tightly associated with mortality, both cardiovascular mortality and all-cause mortality. I'm going to skip over this slide very quickly because the next one actually gives us the more important information. What you've got here is a complex 3D graph, but what you've got on the left-hand side are people with normal, with microalbuminuria, and with macroalbuminuria. On the right-hand side, you've got people with normal EGFR, with a marginally elevated EGFR, reduced EGFR rather, and then with renal impairment. And you can see that the association between the kidney disease and the mortality is far more dependent on the micro and macroalbuminuria. Indeed, the cardiovascular death is higher in someone with microalbuminuria and a normal EGFR than it is in someone with a reduced EGFR and no microalbuminuria. Therefore, when it comes to monitoring our patients, microalbuminuria is the first indicator that you have a potential pathology. And the pathology is very rarely renal failure. Very few people with renal disease actually die of renal disease. They die of the cardiovascular events that it causes. This is the graph that is looked at very, very frequently. What we see that if you are age 60 without diabetes, you've got a normal life expectancy. Whatever that may be for your geographic region and for the other demographics, it's normal. Just adding diabetes on top of any other diagnosis will knock 6 years off your life. With CKD, that knocks 9 years off your life. It's only another 2 years if you've had a heart attack or a stroke. And we tend to think of heart attack and stroke as being the major life-limiting event, when actually the diabetes plus the CKD have knocked off about 85% of your life years that the heart attack and stroke ultimately goes for. And that brings us on to the different diagnoses that we start looking at when we talk about the cardiovascular disease, because we tend to talk about cardiovascular disease as made up of the three big pillars. Cardiovascular death, rather obvious to diagnose, the patient is dead of a cardiovascular cause. And actually for these patients, we can do absolutely nothing. They're dead. However, what we are far more interested in is those early signs. Those with myocardial infarction, that we want to try and reduce the risk of this happening. Because the myocardial event, although a discrete event, will leave longer term consequences. It can leave valve dysfunction, it can leave atrial and ventricular dysrhythmias that can have a dramatic impact on quality and quantity of life. We'll increasingly recognize that a myocardial infarction causes a central nervous destabilization. And this is one of the reasons that we believe an MI leads to subsequent diabetes. But of course, there's the overall medical costs. There's a loss of productivity and the caregiver costs. So these are all essential components we have to have a conversation with our patients when we're talking about going forward. We then have strokes. Strokes have a massive debilitating cause. It's the second leading cause of death globally, and it's one of the biggest cause of reductions in the quality of life of any of our patients. Now, there are many factors that can have an impact on this. There's many factors that are within our control. There's many of them that are without our control. But we have to look at what we can do in order to try and minimize the risk. And when we're managing our patients with diabetes, we manage the entire cardiometabolic consequences. Now, from that, I just want to touch briefly on heart failure, because we speak about the three pillars of cardiovascular outcomes being cardiovascular death, myocardial infarction, and stroke. But heart failure is a very important but under-recognized complication of the disease. It's very often the first presenting feature of cardiovascular disease in a patient living with diabetes. There have been several studies that have identified it in people without a proven MI. In my own MD work, I was looking at the impacts of cardiometabolic disease in different ethnic groups. And one of the key things that we identified is that actually heart failure is far more common than we ever gave credit for. About 68% of our population will have some degree of LV dysfunction within 5 years of the diagnosis of the disease. About 28% of patients with type 2 diabetes will have some degree of heart failure once they've reached the age of 60. And one of the most under-recognized is this is a poorer diagnosis than many cancers. If you've got heart failure with diabetes, your life expectancy is less than most cancers, with the exception of small cell carcinoma of the lung. This all requires urgent treatment. So when it comes to modifying these risk factors, well, there are many pillars that we can base this on. And that can come from things like the multiple risk factor intervention. We have to go for this entire multiple risk factor. And the classic data from this still comes from the STENO2 trial. Very small study, only 160 patients. And people were randomized to receive a multiple risk factor intervention approach compared to identify problems as they arise. And that demonstrated a benefit that has still present 20 years down the line, many, many years after the study was ended and people were all put onto the same approach. So what are these multiple risk factors that we're talking about? Well, first of all, of course, there's lifestyle modification. Now, lifestyle modification is hugely controversial, particularly after the Look Ahead study was stopped due to futility because the lifestyle actually failed to show any benefit. But that's because patients have differential engagement with lifestyle intervention. You've all got them. Patients that if you give them advice and say, you need to lose weight, you need to exercise more, half of them will walk out and say, nah, what does that doctor know anyway? The other half will really take it to heart. They'll go on a diet, they'll exercise on a regular basis. And if you compare the group who actually did engage with those who didn't, those who actually lost weight versus those who didn't lose weight, we saw a massive reduction in cardiovascular risk, in stroke, in presentation to hospital, in needing for any additional components. So lifestyle intervention, although many poo-pooed it as a strategy, is still a cornerstone of the management of patients with any of these cardiometabolic and type 2 diabetes. The next on the list is glycemic control. Now, glycemic control alone is different from choosing specific drugs. Glycemic control alone has a rapid effect on type 2 diabetes microvascular complications. But when it comes to macrovascular complications, actually the benefit is best achieved by doing things very, very early on. Actually, in the UK PDS, which is still cited as one of the reasons for managing glycemic control better, it took decades before we saw a real benefit in terms of clinically meaningful macrovascular responses. And when you look at the other studies that have followed with that, the further you get on in disease progression, the more difficult it is to get benefit from glycemic control. Now, if you compare that to studies that have been recently performed, such as the Verify study, which looked at very early metformin plus DPP-4 inhibitor given on day of diagnosis, what that saw was at the end of a 5-year period, very few patients needed any progression of their diabetes therapy. And although it was a very small numbers, you're not able to conclude things conclusively based on the numbers that they used, there was a numerical advantage when it came to cardiovascular events, even within that 5-year period. So the suggestion is, when it comes to glycemia, what we need to look at is rapid early glycemic control. The analogy I always use with my patients is, if somebody bought you a brand new car tomorrow, would you wait until the car was broken before you started servicing it? Or would you start servicing it from the day that you bought it? Clearly, you'd look after your property from day one because you know it's going to be expensive to replace an engine. Yet when it comes to diabetes management, the strategy seems to be very much about leave it until it's broken and then try and fix it. Now, when it comes to using drugs that are really effective at fixing the broken components, we've got two classes that have really shone in recent times. The SGLT2 inhibitors, that's empagliflozin, canagliflozin, and dapagliflozin, have all demonstrated tremendous benefit in patients with heart failure and renal failure. If you've got a patient with type 2 diabetes and heart failure, or type 2 diabetes and renal impairment, they should be on an SGLT2 inhibitor. And I'd ask you to look closely at what your local licensing, what local is available. But if they've got heart failure and diabetes, or renal failure and diabetes, they should categorically be on an SGLT2 inhibitor, irrespective of what their HbA1c is. When it comes to the GLP-1 analogs, though, we do have a slight discrepancy in the GLP-1 analogs. We've got those that are analogs specifically, and that is the dulaglutide, semaglutide, liraglutide. They are all demonstrating cardiovascular benefit in atherosclerotic events, TIAs, myocardial infarctions, strokes. The GLP-1 receptor agonists, the exendin-4-based drugs, that's lixisenatide and exenatide, actually are very, very good at glycemic control and weight loss, but may not have the same benefit as the analogs. And so therefore, we'd always recommend use of a GLP-1 analog, liraglutide, dulaglutide, semaglutide, in a patient who's had an atherosclerotic event. And speaking of atherosclerosis, that moves on to the third pillar of the multifactorial approach, the management of dyslipidemia. Suffice it to say, we should be getting the lipids down in just about every patient who we are seeing. We should be aiming for a 50% reduction in their LDL cholesterol and a target of less than 1.8 millimoles per mole, or 70 milligrams per deciliter, with whatever agents that are available. I personally would recommend every type 2 diabetic patient should be being treated with a statin. And at that point, you then start thinking, should we be adding in something like an exenatide? Should we be adding in some of the fish oil treatment? Should we be looking at a PCSK9 inhibitor? And these are very much based around local availability. I would say the benefit of the Viaspar, the fish oils, that has been grossly underestimated, has a tremendous use, particularly in our diabetic populations where the statins are not as effective. Then we've got blood pressure control. And right since UK-PDS, we have known that tight blood pressure control is absolutely essential for people with type 2 diabetes. And again, there is a proven legacy effect on this. The longer you leave it to get it under control, the more difficult it is. And the target should be around 130 on 80 if you've got high cardiovascular risk, or 140 on 90 for the lower cardiovascular risk. Lastly, from this multifactorial response, the platelet inhibition is something that has changed since I started practice. When I started training, every person living with diabetes should be treated with aspirin. We now know that that's not necessarily the case. And actually, we only use platelet inhibitors as secondary prevention within a setting of a patient living with diabetes. So if they've got diabetes, they need to have had another event. We only consider them in those who've got a really high primary risk, those who've got multiple risk factors as well as a strong family history. Would you consider the antiplatelets? And that's purely because the benefit of giving aspirin routinely is counteracted by the risk of the GI blood loss or the complications of having aspirin in the lower risk population. So what we have here on this table is just that overall summary. Glucose control, target HbA1c of less than 7%. Metformin plus DPP-4 inhibitors are brilliant as a first-line combination therapy. Then SGLT2s and a GLP-1 analogs can be considered as an alternative to add in if they develop atherosclerotic events. Blood pressure, look at really good blood pressure control with the ACE inhibitors, the calcium channel blockers, the thyroid-like diuretics. Very often, look at dual therapy initially if the blood pressure is not going to achieve target with a single agent. When it comes to the lipid control, we've got very clear guidance. We use a statin first line, then add in ezetimibe, the fish oil or the PCSK9 and get on board there. And always look at weight loss and smoking cessation. Now, there are multiple guidelines these days for looking at the best way of managing them. And these guidelines have shifted from what they used to be. The guidelines when I trained were all about get the sugar down. Now we've got atherosclerotic targets, we've got heart failure targets, we've got renal targets, we've got CKD targets. And in the top right-hand corner, we have the really important component that we need to review regularly. We need to be tackling the clinical inertia. We are no longer happy to treat to fail. We need to try and get these patients under control from day one. On that note, I want to thank you for your attention and look forward to the discussion that we're due to have. Thank you very much.